Now for blood thinners, generally they come in three sizes: small, medium, and large. So by comparison, think of antiplatelets like aspirin and clopidogrel, like water gun. These are the small guys. And anticoagulants like heparin and warfarin, like a bazooka. The semi-big guns, those are the medium. And then thrombolytics, the clot busters, like TPA and Alteplase. Guys, these are the atomic bombs, the most deadly since they have the highest bleed risk. So first up, let's cover antiplatelets like clopidogrel and aspirin, aka salicylate. Now guys, let the name help you here. Antiplatelets are just that. They're antiplatelet. They lower platelet aggregation, so we have a less chance of them sticking together and clogging the arteries. So just think AC for aspirin and clopidogrel, brand name Plavix, like AC for anti-clogging of the arteries, preventing platelets from forming clots. Now the indication is mainly for clot prophylaxis, basically meaning clot prevention. So guys, in heart and brain clot, like an MI or CVA prevention, narrowed arteries like ACS in the heart, or a TIA in the brain, or even PAD in the extremities. Or even prevention after a stent or bypass, preventing the reocclusion of that artery there. Now the HESI key term, we use post-PCI, that percutaneous coronary intervention. Fancy words for cath lab to clear the clot. Again guys, AC is aspirin and clopidogrel. AC for anti-clot. Now the mechanism of action, guys, it's very simple. They prevent the platelets from aggregating together or clumping up. Sort of like spreading them out like a bunch of plates. Now the key points before giving, we always assess. So the key numbers here is hemoglobin levels. So anything less than 7, just think you might be sending your patient to heaven. Huge bleed risk there. And also platelets, normally between 150 to 400. So just think anything less than 150 is very iffy. Always notify the HCP. But less than 50 is very risky. These meds should not be decreasing platelet levels. Guys, this is known as thrombocytopenia, basically meaning a huge risk for bleeding. So common questions on exams, they'll give you a scenario of a platelet count about 75,000 or less than 40, guys. What's the priority nursing action? Always the priority is to hold the drug and question the prescription and then notify the HCP. And guys, don't let the NCLEX trick you. Aspirin and clopidogrel, think platelets, not INR, not PTT. That's for anticoagulants in our next section. Now, HESI had an exit question about aspirin. They were asking about contraindication for patients with hypoprothrombonemia. That's just fancy words for low clotting factors, so we just hold the aspirin. Now, as far as aspirin toxicity, this is a big focus on safety. So HESI and ATI exit exams had a few questions on this. So activated charcoal was the #1 drug for aspirin toxicity. Now the key term here is initial treatment of salicylate or aspirin toxicity. It binds with aspirin to block the absorption by the small intestine. And the key signs of aspirin toxicity is #1, tinnitus, the ringing of the ears, and also hyperventilation. So guys, we notify the HCP immediately. Now, Kaplan mentioned this as a priority finding. Given a scenario about a patient on aspirin who is hyperventilating, indicating it could be a salicylate poisoning or aspirin poisoning. An ATI question about long-term aspirin administration. Priority assessment is assessed for tinnitus. And a very last side note here, tachycardia and hypotension are not signs of toxicity. This could actually indicate a bleed, so just be careful. Now for glycoprotein or GP receptor inhibitors, we have L6amab, also an antiplatelet given for prevention of platelet aggregation. But guys, here's the big difference. It's mainly used after cardiac procedures like a heart cath or coronary stent placement, where we want to prevent vessel reocclusion. Now, adverse effects, guys, just like aspirin, but way more severe. So we still have thrombocytopenia and bleeding. Now, the big nursing care, common exam questions ask actions the nurse should implement. So key terms to write down here. #1 is assessment of hemoglobin and platelets. Again, Hemoglobin below 7 sends your patient to heaven. And platelets below 150 is very iffy. But anything less than 50, guys, is very risky. Always question any prescription or order for any blood thinner with platelets that low. And guys, we assess for bleeding here. We report to the HCP these key terms. Red tinged urine, which could be hematuria, or basically blood in the urine. Or dark tarry stools. That key term came up a lot on various quiz banks. Or it came up as black or bloody stools, basically blood in the bowel. We also monitor groin insertion site for signs and symptoms of bleeding after a PCI. And third, place the client on a cardiac monitor to monitor for ECG changes. And guys, lastly, for no needles, no new IVs or IMs during or after administration, unless it's absolutely necessary, which on the NCLEX, it's never really absolutely necessary. Guys, serious blood thinners are serious bleeding. Now, next up is anticoagulants, heparin versus warfarin. Guys, this is the most tested section of all blood thinners. So to make this a little special, we're doing a side skit. Oh yeah, our anticoagulants slowing down those coagulation times for you, baby boo. No clots here. Our blood is on the super silica smooth, flowing through like a river. Oh yeah. All right, now anticoagulants are given for prevention. The key word there is prevention of new clots and preventing growth of existing clots, specifically with patients recovering from an MI heart attack or those at risk for a DVT, like after a hip or knee surgery. Guys, the key point is that anticoags do not dissolve clots. Only thrombolytics do that, like TPA and alteplase. So guys, don't let the NCLEX trick you. So let the name help you. Anticoagulants are anticoagulation, withholding clotting factors in the coagulation cascade, mainly blocking the formation of fibrin, since fibrin forms the seals on the clot. So for warfarin and heparin, think WH for withholding clotting factors. Now, heparin works quickly and warfarin works slowly. So think heparin works hella fast, like within 20 minutes. Or think heparin starts in a hurry, but is gone in a hurry, and can only be injected into the patient, IV or sub-Q, like enoxaparin, or lower, lighter weight heparin, which we'll be covering in a moment. Now for warfarin, think warfarin is a weaker start, typically taking 5 days to reach full effect. So warfarin takes a longer time to kick in, but it actually lasts longer and can be taken longer. So guys, just think war in warfarin is like a war. It lasts a long time. Now, patients are commonly put on both at the same time. Key word here is both medications are given together for several days. This gives warfarin enough time to catch up. Guys, that was mentioned a few times on a lot of quiz banks. Now, labs, the biggest topic that's tested by far. Guys, most test questions come from here since it's the most deadly for patients. So just think, if labs are too high, the patient will bleed out and die. If labs are too low, then guys, clots will grow. So the key numbers to know, heparin, we measure PTT with a therapeutic range between 46 and 70. And the antidote is protamine sulfate, which is not associated with food. So think hepit is like hepit the frog. Since frogs are jumping fast, guys, heparin goes fast. So H in hepit is H for heparin. And the P in hepit is for protamine sulfate, the antidote. And PTT, the lab to know again, is 46 to 70 max range. Now guys, be careful. The NCLEX is going to try and trick you. So not INR and not a PTT over 70. A common HESI question here was heparin drip PTT 85 or a PTT of 100. Guys, anything over 70. The priority action here is to number 1, stop the heparin drip and notify the HCP. Number 2, prepare the antidote, protamine sulfate. And number 3, reassess the labs in about an hour. Now, a common ATI question, a patient on heparin with bleeding at the IV site. What's the priority action? Guys, key term here to know. Blood oozing at the surgical incision or IV site. Again, same priority actions here. Number 1, stop the heparin, notify the HCP, prepare protamine sulfate, the antidote, and reassess labs. Now on the other side, warfarin, we measure INR, and the therapeutic range is 2 to 3, and 2.5 to 3.5 for heart valve replacements. Guys, therapeutic INR was mentioned multiple times across a lot of quiz banks. Now a side note here, PT, that prothrombin time, we measure that too, but the values were not tested directly on any question banks. Now guys, the antidote here is vitamin K, which you can think kills the warfarin. So the key term is vitamin K, not to be given if warfarin's within therapeutic range, and not to be given until at least 5 days of warfarin therapy when switching from IV heparin. Now guys, vitamin K is found in some very specific foods. Key term here is liver and green leafy veggies like broccoli and spinach. Now the key point for patient teaching is that it should be eaten consistently, guys, and moderation. So just keep the K consistent. Keywords is not increased, not decreased, and not avoided totally. Just a nice, consistent moderation. Now, don't be tricked. Bananas and oranges are okay. That's for potassium, that is a K+, not vitamin K. Now, a common ATI question is a client on warfarin. Which statement requires intervention? Well, the statement that includes, I will increase my intake of dark green leafy vegetables. Guys, that's a big no-no, vitamin K. Now, a side note, that's a nice to know. Antibiotics actually increases the risk for bleeding by increasing INR. This is because antibiotics kill the intestinal bacteria that produce vitamin K. And we end up with a vitamin K deficiency, which increases our risk of bleeding. Now the big key point and memory trick here, guys, write this down. Warfarin, think warkin. Since warfarin takes so long to set in, you're wondering if it's warkin. So think W in warkin is for warfarin. The K in warkin is for vitamin K, the antidote. And warkin, ending with INR. 2 to 3 is the therapeutic range. Now some common exit exam questions here. Giving an INR of 4 or 5. Guys, we're assessing for bleeding and we're getting that vitamin K antidote ready. Or, on the other side of things, the INR of a 2.0 with a patient with ischemic CVA. Guys, we give warfarin to get up to 2.5. Now for patient teaching, warfarin is taken lifelong to prevent clots, like with patients with atrial fibrillation or artificial heart valve replacements. Typically more prevalent in, key term here guys, write this one down, mechanical valve replacements. So another key term, we always do frequent blood tests, definitely needed, to check therapeutic range. Now heparin's different in that it's typically only given for a few days or a few weeks. So heparin IV is usually given after an MI heart attack or a PE in the lung to prevent the clot from growing. And heparin sub-Q ends in parin, like heparin. So just think enoxaparin or enoxaparin, brand name Lovenox, or dalteparin. Guys, these are lower molecular weight heparin, basically a lighter version, sort of like a Diet Coke. They're just less heavy and a less chance of major bleeding, which is a great thing. Now it's given for a key term, prevention of a DVT after surgery. And as far as administration, we use a 25 gauge needle with 5/8 of an inch. We inject 90 degrees angle. And location, keyword, 2 inches from the umbilicus, or basically the belly button. Guys, not in the thigh, not IV route, so don't get tricked with those common distractors. So, number 4, the big no-no here. Never aspirate a sub-Q injection, and guys, never rub the site. Now a key point, and This one was stressed on the Hesse. It's normal to have mild pain or bruising or even irritation and redness at the site. Guys, there's no need to notify the doctor, and you may use ice chips to help with irritation. Now, a common ATI question is enoxaparin. Which statement needs further teaching? Well, the statement that says, I will inject the med into my thigh. You guys know in the umbilicus, near the belly button. And I will need frequent blood tests. You guys know that's warfarin. Now, two special considerations for that low molecular weight heparin. We always assess the H&H before, keyword, given to clients with open fractures. Now, we always notify the HCP and clarify the order of enoxaparin if the H&H is even slightly low. Since, guys, we don't know exactly how much blood has been lost. So, open fractures and H&H low, then enoxaparin is a no-go. Now, a common Hesse question was, a client on enoxaparin, what do you report to the HCP? And the answer was H&H that has been decreased and a blood pressure that is dropping. In that scenario, it dropped by 20 points. So guys, decreasing H&H with decreasing blood pressure usually means blood loss. Now, as far as labs for enoxaparin, our low-weight heparins, we monitor for those low platelets. Guys, we're not monitoring for coagulation studies. So not PTT and not INR. This was the most commonly chosen distractor. Over 30% of students got this wrong. So guys, think of the double P's for parins. So P for parin in enoxaparin, or enoxaparin, is P for platelet focused. So just like aspirin, the key numbers here, platelets should be between 150 and 400. And guys, we hold the med for any platelets less than 50. So less than 50 gets really risky. We hold really any blood thinner. Now, another risk is a deadly condition from any type of heparin. Now, this is called HIT, or heparin-induced thrombocytopenia. This happens if platelets are decreased by half within, key number here, 24 hours after starting heparin of any type. This usually indicates HIT. Guys, very deadly. So think of the triple H's here. H for HIT is when half the platelets are gone within 24 hours after starting H for heparin. Guys, the priority action is number one, alert the HCP. This was mentioned in multiple hemosections in 3 different quiz banks. Now lastly, a new one on the market is fondaparinux. Now the major advantage to this is no risk for HIT. But the major disadvantage is key term. It can cause epidural bleeds. So we don't give it to a patient that's reporting severe back pain, decreased LOC, or paralysis. We always call the HCP and hold the med. So, key terms here. No fondaparinux for at least 6 hours after surgery. And no anticoagulants while a spinal epidural catheter is in place. Huge risk for epidural bleed. Now, a new oral anticoagulant for atrial fibrillation patients, Endinzaban like rivaroxaban. Now, the brand name is Xarelto. So the memory trick for rivaroxaban, just think of a river rock band, because blood flows like a river. Now, the key point is we avoid aspirin with rivaroxaban while taking this medication. So avoid any and all over-the-counter medications that increase bleeding, especially NSAIDs and supplements like Ego, so vitamin E, garlic, ginseng, and ginkgo. Guys, even omega-3s, but we cover more of that at the end of this lecture. Now, the good news here is that there's a lower risk for bleeding when compared to warfarin. And no, there's no need for routine clot studies. That was a commonly chosen distractor. And no, you don't need to avoid all that vitamin K, such as those green leafy and liver. So guys, eat up that spinach and that liver. Now, the bad news here is there's a risk for neurological impairment. So just think rock band causes brain bleeding from just too much head banging to that rock band with rivaroxaban. Now, Hesse, there was a common question for rivaroxaban. We teach client methods to reduce bleeding. That's the biggest test tip there. Now the next drug is dabigatran, used to prevent clots in high-risk AFib patients. Now the key point here is do not stop taking the med for GI issues. This is considered a normal side effect. So yes, take the med even if the stomach hurts. And guys, just make sure we're not pooing out blood. Key term is black tarry stools. And do not store in a pill box, always in the original container. And do not crush, make sure you take it whole. So the memory trick for dabigatran is take the big pill whole. Do not crush it. And the other norms here, hold clopidogrel or aspirin, and hold before surgery. Now, Hessian ATI had a question about this med, and the question goes, which med do you hold before surgery? It was dabigatran. And as far as the Hessi, it was patients on dabigatran do not take clopidogrel. Two big test tips there. Now for thrombolytics, our clot busters, our atomic bomb, the most powerful one-time push-only drugs. Key term, clot busters. So the names include TPA and those ending in ACE, like alteplase or retalpase or even streptokinase. Guys, these are the only ones that dissolve clots. Aspirin and clopidogrel are not clot busters. They're antiplatelets. Heparin and warfarin, not clot busters. They only prevent new clots and existing clots from getting bigger. Now, these clot busters can only be given between a 3 to 4.5 hour window from the onset of the signs and symptoms. So the window is very narrow. And guys, the big caution here is its massive bleed risk. And it's the most deadly. So guys, make sure no injections at all. Key terms, no IVs, no sub-Qs, no IMs, and definitely no ABGs. These drugs can only be given through a compressible site, like a peripheral IV. So guys, we never give clot busters through a central line where you can't hold pressure, only through peripheral IVs that can be compressed. Now the absolute contraindications because of the big risk for hemorrhaging, we avoid giving to any patients with number 1, an active bleed, like key term, peptic ulcer. Number 2, uncontrolled hypertension, anything 180 over 110 or higher. Number 3, recent surgery within 2 weeks, big key term right there. Always clarify prescription with provider. Huge on NCLEX and exit exams, since our number 1 priority is patient safety. And then lastly, the 3 A's, accidents or recent traumas, A for aneurysm or history of hemorrhagic CVA, aka a brain bleed from a stroke, and A for AV malformations. Now, as far as patient teaching for the bleating, we're highlighting only the need-to-know stuff for the NCLEX. But first, we're going to do a quick recap to reinforce the highly tested key numbers. So, key numbers here, 2 to 3 INR for warfarin. Antidote again was vitamin K. So the memory trick, warkin. So warfarin, vitamin K, and in for INR. Just think warkin. And you wonder if it's working since it takes 5 days to reach full effect. Next is 46 to 70 APTT for heparin with the antidote protamine sulfate. So the memory trick was hepit, like the frog. H for heparin, P for protamine sulfate, and PTT for hepit. And since heparin acts fast, just think the frog jumps really fast. Lastly, 150 to 400 platelets. Look for the P's, guys. So aspirin, clopidogrel, and enoxaparin or enoxaprin. Guys, P for platelets. The key number here is less than 50 gets really risky. Guys, thrombocytopenia is 50,000 or less. So we even hold any type of heparin. Now for patient teaching, the big contraindication here, and to be honest, for any blood thinner, is key term active bleed, like a peptic ulcer or peptic ulcer disease. And we always avoid any patients with liver problems since the liver makes coagulation factors. So we use the acronym CHANT. C for cirrhosis, H for hepatitis, A for alcohol. Key term on the HESI was a client just drank 6 beers. N for NSAIDs, and the ATI loves to name naproxen and ibuprofen. And T for Tylenol overdose, leading to liver damage. Now we monitor signs of bleeding and we notify the HCP ASAP. Keywords used on ATI was black tarry stools, usually indicating a GI bleed, hematuria, or blood-tinged urine, epistaxis, or nosebleed, and even petechiae on the chest, mentioned by HESI, and easy bruising. Now, supplements to avoid completely. No Eggos, guys, like that old waffle commercial. Lego my Eggos. E for vitamin E, G for ginseng, ginkgo biloba, and, well, garlic, and O for omega-3s, and the S is for St. John's wort. Lastly, we avoid trauma, so the big key terms used on the HESI: no small rugs or dim halls, always well-lit hallways. No brushing hard, we use a soft bristle toothbrush. No flossing, no alcohol-based mouthwashes. No razors, only electric shavers. No constipation, only fiber and fluids, guys. And no contact sports. And we always wear a medical alert bracelet. Now, 3 common test questions. Number 1, when do you hold heparin and contact the HCP? Select all that apply. So guys, heparin, just think HEPIT. We're looking for PTT between 46 and 70. Anything north of 70, we gotta call the doctor. So, patient has recent diagnosis of peptic ulcers. So, we're gonna be holding that medication. Number 2 is patient has a PTT of 105. Guys, that's way north of 70. What about option 3? Patient has an INR of 4.5. Nope, that is warfarin, not heparin. How about 4? Patient has black tarry stools. Yes, that could be indication of a GI bleed. And patient has a PTT of 25. Well, that's under 46, so just keep on giving the heparin for sure. And lastly, patient is taking ginkgo or vitamin E. Guys, definitely hold the medication. Huge risk for bleeds. Now, question number 2. When do you question the order of aspirin or clopidogrel? Well, guys, the P for platelets, we want it to be over 150. So aspirin and clopidogrel for platelets. So option 1, the patient has 65,000 platelets. Guys, that's way less than 150, so it's very iffy. Number 2, patient with 1.5 INR. Number 3, the patient with 46 PTT. Again, that's heparin with hepit, the frog, so no, not a platelet thing. Number 4, currently taking warfarin. Yes, guys, we want to hold this medication because we don't mix aspirin or clopidogrel with an anticoagulant. And number 5, regular consumption of 6 glasses of wine per night. Guys, we're not doing alcohol for sure. And lastly, another common question. A patient on dabigatran for AFib, which action should the nurse initiate? So guys, number 1, place an IV line. No, we're not trying to place an IV line here. And we indicate a big bleed. Number 2, report stools that are black and tarry. For sure, that's a GI bleed. Number 3, teach the patient to avoid clopidogrel. Most definitely. Number 4, administer aspirin instead. No, big no-no, we do not mix. And number 5, teach the patient to stop taking this med before surgery. For sure, definitely want to do that. All right, guys, that wraps it up for our blood thinners. Thanks so much for